Great. Thank you so much. It's a pleasure to be here and always a pleasure to see so many friends. I'm going to be discussing refractive surgery options for patients with keratoconus. I have no significant financial disclosures. When I talk about different opportunities for keratoconus patients to have refractive surgery, mostly we're discussing options after cross-linking, and I'll go through several. Of course, you want to evaluate the refraction of the patient, AC depth, the age, pachymetry, all of these things come into play. Let's go through some cases. The first is a 32-year-old who came to see me. Here were his refractions. You could see that he basically had pretty typical keratoconus. He had a high myopia, a lot of astigmatism, typical keratoconus patient, elected to go ahead and do cross-linking. And I let patients know when they come to see me and they want to have something done that we're on a journey together. And the journey is going to take well over a year. I'd like to do the cross-linking first, wait a year, because as we know, there can be refractive and will be refractive changes. And here we can see that 1 year after cross-linking, the patient, in fact, had a decrease in both myopia and astigmatism. This was just for cross-linking, and an increase in best-corrected vision. Following this wasn't enough. I mean, we knew we were going to do cross-linking to help stabilize the cornea, and then chose to plan an EVO ICL. One of the questions that comes up with the ICL is, which axis do you use? The Penacam axis featured here was 82, but the manifest was 105, and in the other eye it was very congruent. But there's always the question, which axis do you use? I tend to use the manifest axis of refraction, and in fact, here was the patient. 1 month after ICL, we could see that he already had just a minimal refraction. And again, these patients are going to change over time. Part of that is because after cross-linking, they're still going to be changing, right, even after a year. This is just a typical ICL implantation. Tucking the haptics, you want to do that, of course, at that little junction of where the tiny nub is, and not at the optic haptic junction because it's less flexible there. 6 months after, you could see here that the patient was 20/20 uncorrected in the right eye, and the left eye just had minimal refraction, and so patient was really quite happy. You also have to counsel the patients that the goal is improvement and not perfection. We're talking about someone with a diseased eye, and I make that very, very clear, as well as the fact that they need to be patient. Of course, that's easier said than done. Next case, this is a 28-year-old woman, and she was already post-cross-linking. Here were her refractions. And for her right eye, because it was very minimal keratoconus, I chose to do an ICL, and that was pretty good there. And for the left eye, because it was a little bit more complex, I decided to do topo-guided PRK. I wait. I don't do them concurrently. You can do them concurrently. I tend to wait because I know there's going to be some refractive change when we do the cross-linking alone. So following this, we did topo-guided PRK. This is with the Foricides and Contora is what I did. And you can see here that she really had a pretty good result in terms of flattening. Also interesting, the 1 month post-op, she's going to change, continue to change at 6 months. And then here was a year after, and you can see the before and after with the tomography. She ended up with 20/40 uncorrected vision, best correcting to 20/20 with just a minimal refraction, and was really quite happy. So again, topo-guided PRK, yes, another option for patients with keratoconus, following or in conjunction with cross-linking, your choice, but make sure the patient knows that we are going for improvement and not perfection. This is another case courtesy of my good friend Bill Wiley. This is a patient who had post-LASIK ectasia, as you can see here in the one eye, and he does a lot of, here's his video for CTAC. This is essentially femtocares. And what you can do is with the femtosecond laser, you can make the channel for the segment, and then he goes ahead and, which is, I think, is very helpful too, even if you use a femtosecond laser, going in and opening the channel just makes life easier for yourself, and I'm all about making life easier rather than more difficult. And so you can go ahead, if you happen to have the manual Intax separator, you can go ahead and use that. If you don't, just use whatever you have to try to at least widen the entry, and that will really be helpful when you go ahead and put in these segments. The segments are custom made for the refraction, and you have to kind of stuff them in. They don't, I mean, they go in pretty well, but you want to make sure your channel is wide enough. And here was the pre and post-op, looking at the different maps. And again, you want to emphasize that we're going for improvement rather than perfection. This is another case. This is a 67-year-old woman who came to see me with history of keratoconus. And for her, she also had a cataract. Options, just because a patient has keratoconus doesn't mean that they don't deserve to get the best vision possible. And if appropriate, I offer them either a small aperture, the IC8 lens, or a toric lens. Both can work very well with the right patient selection. Here you can see this was pre and post-op, and this was, you could see the IC8, it's nicely centered, and you do get a variable amount of astigmatism correction with the IC8, but again, we're going for improvement, not perfection, since these are abnormal eyes. A last case here. This is a patient who came to see me. She had uneventful cataract surgery about 8 weeks before with a toric multifocal lens. The error of the referring surgeon is that there was no tomography or topography obtained beforehand. And you can see here this patient clearly had keratoconus, and that's why they were completely miserable. And for this patient, what I went ahead and I did a IOL exchange because there's really no other option. So I like to cut the IOL in 2 places and then just kind of twist it out. It tends to work really well. And for this particular patient, I went ahead and I injected a toric lens, and that seemed to actually do quite well. I choose a low power toric. I could have also chosen just a plano monofocal. With the platform that I chose, it's an aberration-free platform, and that minimizes additional higher order aberration that you're going to add for the patient. So essentially, in summary, there are refractive options for patients with keratoconus. All patients deserve to optimize their vision. Even patients with keratoconus can be offered refractive procedures to enhance their vision. The goal is to improve and not perfect. Just because the patient is very, very impatient patient, right? And just because they're on this like wild roller coaster ride doesn't mean that you have to get on with them. Okay, you can remain calm. Let them know that just because they're pushing you to have a procedure doesn't mean that they need to have a procedure right away. And I let them know that, again, we're on this journey together. If they're too impatient or they don't want to wait, then they're not a good patient for me in my clinic. And so you can offer them, again, ICL, topo-guided PRK, CTAC, and different IOL options depending on all of the aforementioned criteria. I want to thank you very much. It's always a pleasure to be here and to see so many friends. Thank you.
Great, thanks, Audrey. That's excellent. Any questions?
Nice talk, Audrey. 2 observations. ICL, contrary to IOL, corrects the total eye refraction. So why look at the corneal astigmatism axis and not correct what the refractive
Well, that's what I
is?
did, actually.
Yeah.
I just like to look at it to see what it is.
Okay.
But yes, I go with the manifest.
Okay. The second thing is, I do CARES and TCAT cross-linking, but I do the TCAT part and the CARES part first, along with or a little later with cross-linking. You seem to be doing it reverse.
Actually, for
when you fix the cornea, how can you make it?
Well, for CTAC, it's the opposite. Mostly, if I'm doing an ICL, I do the cross-linking first.
Yeah.
But for CTAC, no. For CTAC, yes, we do the CTAC first and then cross-link to.
For TCAT, topo guided?
That I actually do the cross-linking first,
Why? Why do it?
because I know that that's going to change the refraction. And sometimes for some patients, changing the refraction alone with going ahead and doing the cross-linking is enough to get them into a better scleral lens fit, and then maybe they'll be happy enough and they won't want or need to have another refractive procedure.
I mean, also typically for TCAT, when you do topography guided treatment in keratoconus, the cases are not as severe as where you do a KERS or a CTAC segment,
Yeah.
right? So that's you're comparing a refractive versus a therapeutic concept. But on that line, Audrey, I was going to ask you, what's the maximum depth for your topography guided treatment that you'd ablate? Because that's always something that people worry about and stuff.
Yeah, well, it really depends, I would say, and I like to leave a minimal depth of about 350.
350, yeah.
Yeah.
50 microns is the play that that normally I do.
Yeah, 350.
Maximum of 50 microns topo guided. Something equivalent to knocking off the epithelium.
Yeah, I do a little more, but and sometimes combined treatments. It just really depends on what it looks like. But I don't have like a one size fits all. I think I see Prashant in the back there.
Yeah, very nice talk, Audrey. And my question is related to at what time point will you use any of these procedures following collagen cross-linking? Because you keep seeing variation in the topography in some patient even up to a year or even longer.
Yeah, I mean, that is why I emphasize to patients we're improving, not perfecting. Their vision may continue to change. And that's why I tend to wait a year after cross-linking. I know, yes, it can still change. And as I presented those cases, it's really interesting, right, that, initially they may have one result, and 6 months later it can change, and a year later they're happy. It's very possible that if I see them back in another year or two, I may then have a hyperopic patient. I don't know, but that is certainly one of the things, and that's where the hopefully managing expectations comes in. And I tend to also plan on a little bit of residual myopia in addition.
Oh, okay.
Yeah.
Ma'am, while planting ICL in keratoconus patients, do you modify the anterior chamber depth?
Do I modify the anterior chamber? Oh, because of the K readings, you mean?
Yeah, because the posterior cornea is ectatic, so that might be a factor that is changing the anterior chamber depth in cases of ICL, and that will determine the size. Also, white to white, how do you calculate in patients who are having allergic eye disease, like they might be having hyperpigmentation around the limbus?
I do it with the Pennicam. I usually go with that.
Okay.
And so, yeah, I mean, you're right. You need to look at all of these different factors. Fortunately, not with all patients, but with a lot of patients in keratoconus, they tend to have, big anterior chamber depths, which is nice. But yes, that is absolutely something that you have to be aware of. There's now online calculation formulas, which can be helpful.
Do you change any of the anterior chamber depth parameters in your online calculator, or just you put the internal anterior chamber depth that is provided by the Pentacam?
I put that's provided by the Pentacam, and then I carefully look at, at everything. I never use biometry anterior chamber depth, because that always overestimates it, and you'll get into trouble.
Okay. Ma'am, one more question. During cataract surgery in keratoconus, which IOL formula would you prefer?
I use the Barrett keratoconus.
Barrett keratoconus.
Yes.
Okay, and what is the target refractive error that you plan?
Oh, that's a good question. Yes, for target refractive error is about a -1 to a -150 or so.
In all grades of keratoconus, or for the advanced cases?
Pretty much all. I find they like to have a little bit of residual myopia, and again, they know that we're improving their vision but not perfecting it. I find that they're happier if I leave them a little bit of residual myopia, and it gives you a little bit more of wiggle room there.
Okay, thank you.
Great.
Cane is also good for keratoconus.
Yes.
Cane formula is actually quite accurate as well. Or just you showed one nice case of ICA as well. I was just going to ask you, I mean, obviously a lot of cases are asymmetric, but say in a case where they have, very equivalent, I mean, just your thoughts on bilateral implantation of ICA in this
Oh
situation?
yeah, I actually do bilateral implantation of IC8 quite a bit. I use the IC8 only in irregular corneas. So keratoconus or RK, previous RK, I just love. That's my go-to lens. And so I have a number of bilateral implantation. And for these irregular corneas, I think that's really their best option.
Great. Okay. Any other questions?
Yeah. Thanks for the nice presentation. So I'm just if I heard that right, you're not doing cross-linking or anyone else in the room in patients who actually need cataract surgery, because I'm presuming those patients are going to be old enough not to need any cross-linking. Am I right?
Well, yes, with the qualification of I have done and do cross-linking in older patients. Sometimes it's for a better fit of a contact lens or something like that, or if there is progression. I've seen progression of keratoconus even in patients over 60 years. Now that's rare, and usually they're an eye rubber, but unless I see that there's been some progression, or I think there's progression in the keratoconus, no, I don't bother with cross-linking before doing cataract surgery.
Thank you.
So if you see very nice talk. If you see an older patient with keratoconus, do you always wait for the and visually significant cataract? Do you bring them back in 6 months to look for progression, although it's unlikely? And then my other question is, so you mentioned torics in keratoconus patients, which I do as well. Can you give us some tips, because it can be tricky, and sort of thinking about how to evaluate if they're a good toric candidate, and then also sort of thinking about which axis you use and so forth.
Yeah, it's always tricky, right, with the keratoconus patients in terms of toric lenses and toric axis. I take a look at the astigmatism. If it's a really, really decentered cone and the astigmatism is a mess, they're not going to do well with a toric lens. And so then I may go for an IC8 or maybe just a plano. It just really, or depends on that. But if they have that, you know how some patients have that, I would call it a more regularly irregular astigmatism, then those are the patients who are going to do much better with, in fact, a toric lens. And in terms of axis, I tend to go, well, I take a look. I measure the axis all different ways. I look at my biometry, I look at manifest, I look at, which of course is a little off because they have cataract, and then I look at the pennicam, and kind of look at all of those different things. I tend to veer a little bit more towards the pentacam axis in those cases, depending on what the pentacam looks like. And again, these are more mild keratoconics, right? If it's really severe, and sometimes they just need a DALK or PK. I mean, there's no, and then I tell them we'll do that, and then a year later we're going to go ahead and do your cataract surgery with a lovely toric lens, and then we can really make improvement there. So I'm sorry, I forgot your first question.
When you're seeing the cataract and the correct, do you check for progression of the
Oh, I do not. No, I don't. Not unless there's some reason, like the optometrist who referred the patient said, oh, I noticed a change in the K readings. That's a little bit unusual. Then I may, see him back in 3 months or something, but depends on the density of the cataract.
I think in these situations, you can do the aberrometry. So that will give you the split of the aberrations. A part of it, like how she has told, will fit into the regular astigmatic pattern, and some will be because of the coma induced. So if you can quantify those, then you can get a mental picture. Patient has -6, maybe 4 is the regular astigmatic part, and the 2 is from the coma. So you leave the 4-2, you can decide between 3.5-4 to be on the safe zone.
I mean, one of the key things, though, in basically doing cataracts and keratoconus is whether the patient's wearing a contact lens. That's the key thing to basically, in my mind. And so if they're wearing a lens, you have a massive runway of what you're going to basically be able to achieve. And I mean, that's going to give you the options and variables as well to then give you an idea of what lens you can basically then put inside the eye. And then you can basically take it from there. Of course, the ones that are very challenging are ones with a sort of, let's just say, moderate case. And they want to basically try to be spectacle independent. That's when you really get have to come up with all these sort of tricks basically to try to do that. But if they're wearing a lens, I think you have a bit more of a runway basically of what you can do from that.
If they're wearing a soft lens or glasses, then they might be better candidates.
Because their vision by definition probably is better than if they're wearing RGPs. But if they're wearing RGPs and they're happy to wear them afterwards, then it's going to be easy for you to decide there. Okay. Any other questions from anyone? For any of the speakers? No, great. So I'd like to thank all the speakers for their great presentations.